Hello, I'm Robert Hickingbotham. I'm a director with Synonetics. Synonetics is a technology company that has been working with the Yorkshire and Humber Care Record for a number of years now, and I've personally acted as an architect for that particular program. Jason.
Good evening. I'm Jason Broch. I'm a GP by background, but I've been in clinical leadership for, well, over 10 years now. As part of that time, I've been involved in a few projects with developing interests around population health management, informatics in healthcare, and also innovation and transformation. And currently, I am the clinical lead for the Yorkshire and Humber Care Record project. Do you want to go on to the next slide, Rob? Okay, fine. I think just setting a little bit of a background to what the Yorkshire and Humber Care Record is, and trying to understand some of the pressures that are being faced by health and care currently. And a lot of this is not just UK specific. These pressures are probably universal, especially highlighted by the effects of the pandemic as well. But effectively, for many reasons over a large number of years, care has been very siloed into multiple different organisations, and that's been partly because of the organisations that are set up in care, but also the way things are funded. We're seeing an increase in demand. Mostly that has been because of the change in demographics to older, frailer people, but obviously demand is even greatly increased now because of the effects of COVID as well. But interestingly, because of the way that funding happens in care, organisations aren't necessarily incentivized to work together. And actually the systems that they use don't really communicate that well. So, I have a record that I use as a GP in my clinical practice, and that's completely different to the health record that is used within maybe my local trust. It might even be different to the health record that's used in the GP practice just maybe 20 miles away. So there are loads of different systems, which means that not only care, but the information around that care is siloed. And there are huge questions now about, well, how sustainable is it to operate in this way, where there must be loads of duplication. So, okay, change the next slide, probably that's fine. So in January 2019, there was the publication of the long-term plan by NHS England, and this sort of concrete some of the strategic direction that we're working in. So the key things that are trying to be delivered are making sure everyone gets the best start in life, delivering world-class care for major health problems, and supporting people to age well. Those are the priorities. How are they going to do things differently? And on the side there, you can see the 5 points that were really underpinning it. But a key point I've put in bold there is making better use of data and digital technologies. And in many ways, that's because there's a recognition that that siloed way of providing care, that siloed information doesn't work. And in fact, digital technology is transforming every other industry apart from healthcare, really. And so we need to get the most out of that. Robert, if you want to move on. The outline model that NHS England presented was a rehash of the primary care home model that the National Association of Primary Care presented. So whereas at the moment, you have care in the community, loads of fragmentation, and you go through a GP gateway to access those other services, the idea of the primary care network ambition, and definitely within the primary care home model, was to say, actually, let's turn general practice and primary care into a facilitator of teams working around geographic populations of 50 to 120,000 people. Because if you have a team of people working together and they know each other and they know the people that they're looking after, you're likely to be able to manage more because you'll have more information locally. But of course, that sets quite a few problems if those people working in those teams are using different information systems, have different ways of working, and are still very siloed in the way that they work. But that's the basic ambition that underpins the integration agenda in modern health and care systems. Next slide. And the business model is going to change. So whereas in the past, what we've normally done is say, well, actually next year we need so many hip joint replacements, and that's how what we paid for. We bought activity in that regard. There's a move to being more intelligent about how we actually buy healthcare. So try and understand our populations, understand the needs that they have and the common needs. So what are the populations of common need? And what is it that we're trying to achieve for those people in terms of keeping them well rather than fixing them when they're unwell? How do we become more proactive? And there's a recognition that in order to do that, we need to be looking at outcomes rather than outputs, and also understanding that providers, that people who are providing care, need to work together in a more integrated teamwork. Next slide. Roughly put, this is called population health management, how we use integrated information to really understand our populations, identify the gaps that they have, and more specifically understand the risks. So, when we identify a population of maybe frail individuals or working age adults or children or people with mental health conditions, actually trying to understand that population, the needs and the outcomes that you want to do, and then stratify the people within those populations is key. So then working with people to come up with ways of intervening or supporting them and managing care, and then most importantly being able to see the impact of what you do to monitor those outcomes. And if we are really going to get there, we have to be honest with ourselves in most health and care systems that actually we don't have those business capabilities to support that way of working. As you'll see in some of the business capabilities on the right, even applying actuarial skills, even applying measuring outcomes requires those three things, which are integrated informatics for patients, integrated informatics for people providing care, and actually integrated informatics for people that are trying to design healthcare systems. That's really important. Now, in order to do that, we need to start somewhere. And the most important thing is saying, well, actually, if we've got information burrowed away in siloed proprietary systems, how do we put in place the technology to be able to share that more effectively, whether it's for direct care, delivering care, or whether it's for those analytics type things that we're talking about in order to underpin this. And in many ways, the Yorkshire and Humber Care Record programme that came out of an initial programme from the NHS called LICA, Local Health and Care Record Exemplars, is a foray into trying to put in place the infrastructure to allow us to work in that integrated informatics arena. I'll hand back to Robert to go through the technical aspects of that in a little bit more detail.
Well, thanks a lot, Jason. Yeah. So I think it's my job to try and take you in under the hood of the Yorkshire and Humber Care Record so as quickly as possible, and it'll allow us to talk a little bit more about how the Yorkshire and Humber Care Record is supporting formal clinical process modelling and how that's improving care. The Yorkshire and Humber Care Record has been under development for the last 3 years or so. It's different from many other shared care records in that it's not a data lake. Its focus is making available information to those who have it, data providers, making that available on demand to those who require it, data consumers, without terribly much definition of what either a data consumer or a data provider is. The Yorkshire and Humber Care Record is centralised infrastructure which exposes a longitudinal care record to allow data consumers to issue queries that are pertinent to what they're doing with the care record, but to take those queries out and to replay them against data providers. So the data provider is expected to offer their segment of a longitudinal care record at their boundary in a very standards-based format. The Yorkshire and Humber Care Record relies very much on a FHIR standard. This is a standard which I can talk a little bit about later on. But the FHIR standard provides us with a mechanism not only for representing data in a uniform manner, but also for providing endpoints, APIs to allow access to that data. So a very basic data consumer is a care portal. our ambition in Yorkshire and Humber is actually to render data in the systems of choice for clinicians, rather than having them move out into a portal or even have a portal embedded within that system. But that's not possible for all the clinicians across the region, and so there is a care portal which allows querying of data for direct care purposes. But that's certainly not the limit of what we consider to be data consumption. We put data in the hands of our patients through a patient portal, and we also provide access to data to a population health management suite. The PHFM suite is different from the rest of the platform in that it does actually persist data. But normally when data is being accessed for the purposes of direct care, a clinician will ask to see maybe appointments for the patient that they're attending to, and that query will be distributed across the Yorkshire and Humber Care Record, and data providers who have got appointments for those patients will echo them back, and they will be rendered within the portal. The Population Health Management Suite, in order to actually derive insights about what's happening in the health and care system as a whole, requires a mass of data, and that can really only be undertaken if data is assembled in a particular location. So the PHM platform acts as a consumer to the Yorkshire and Humber Care Record, but the data it acquires is persisted, and data is acquired for many patients simultaneously. The FHIR standard offers mechanisms to allow the PHFM platform to acquire data in bulk. It allows asynchronous queries to be placed with the central infrastructure. An asynchronous query is basically a request for data where there is no expectation that the request will be serviced in real time. The query will be received by the cloud-based interoperability suite, the exchange, and passed on to data providers who will service the query over a period of time, and results will be echoed back into the PHM platform as they require. They're required. The PHM platform can then issue subscriptions to maintain data, keep data up to date. So once the critical mass of data has been assembled, then a drip feed of future data can be placed actually in the platform. There is an anonymization. The data is anonymized as it moves into the platform, so it's no longer identifiable to a patient. Jason, can I hand back to you to talk a little bit about how YHCR is changing care?
Yeah, okay. So the fact that the information is more interoperable and can flow presents certain opportunities. So number one, direct care. Just the basic idea of having information that's available at the point of care that is from outside your own organisation is help. So we can all easily accept that in an emergency situation, when someone presents, say, at an A&E department, if you've got information from their general practice, you've got information from their social care record, actually suddenly you can start building a picture of that person and make sure that care is more appropriate. Some of the initiatives that we've been doing as part of the Yorkshire and Humber Care Record, especially in Humber, Coast and Vale at the moment, have been about making sure end-of-life care plans and wishes are available in all care settings, and that allows people to make sure that when they are forming plans in situations, they're aware of everything that they need to be. But also, more interestingly, because the information flows, you can start thinking about workflow across organisation. And if you think back to that primary care network, primary care home model, actually being able to share information, share a record, means that we can start looking at more integrated services and assessing how we're doing for people a lot easier. The other thing, of course, it does is allows us to personalise the care better. So as care needs become more complicated, the importance of personalisation is really important. But it also makes us think wider than just the problem that we're faced with. And I think there was an interesting comment in the chat by Mary, actually, where she's pointing out that there is wider issues than just medical conditions. So, if you've got someone who's recurrently presenting with an exacerbation of underlying lung disease. And actually, as part of that integrated health and care record, you can see that there are concerns around dampness in their home. Actually, you've really got to be thinking about, well, do I just keep patching this up and sending them back? Or have I got the integrated information to be able to say, actually, this is more than just medical. This is about the wider determinants. How am I going to get the local authority involved in making sure that that damp is sorted as a priority? So it opens up the way that you look at care, so you can be more holistic and personalised in the way that you do that. The information collectively, though, allows us to understand how people might be accessing services across health and care. If we get the right technology, it might tell us what's happening in care homes. It might even tell us how the third sector are being involved in care around individuals. But it also then helps us to create those ideas of populations of need, people who tend to access in similar ways, have similar needs, and might behave in certain ways. And therefore, we can start thinking about how do we shape our services in order to cater for those needs, behaviours, and even potentially impact them. And a really interesting example of where there's been quite success around these type of things is in Ribera Salud. It's an integrated care system in Valencia, where actually that holistic information is being used to create insights that are provided at the point of care by clinicians every day, so they can base their working day on the gaps that are being identified in care, and ideally helping keep people well. Also, that integrated platform, if you like, of information, although we're using a lot of this, anonymizing it and using it for population health management as well, the other thing is that it allows other technology to interact with it. The FHIR standard gives us the opportunity to have that interaction. So it opens the door to being able to use, Fitbit information or Apple information or personal care records. So actually, we've got the ability here to bring people in and have ownership of their care, and that's something that has often been highlighted as something that is missing. Empowering people to be able to be part of their care, access to their information, because we're not just talking about an analytics tool here, we're talking about clinical utility, an integrated record that is shareable for direct care as well as population health management. And I always like to give an example of how just having that technology as an enabler can really help or change the way that we develop care. And it's a personal story. When we first introduced the Leeds Care Record in Leeds, which was very similar to what we're trying to do with the Yorkshire and Humber Care Record. In my practice, we had the Leeds Care Record, and that allowed me to see any of my registered patients that were currently in hospital, and we routinely check that to see if there's anything that we need to do proactively. We noticed that one of our patients had been admitted overnight following a hip fracture, and she was on an orthopedic ward. And because we knew that person, we knew that she was an informal carer for her husband. He had early dementia, and although it hadn't been spotted, we knew that he probably wouldn't be able to cope now that he was home on his own. And so we were able to proactively put a team in place and a package in place to make sure that he was cared for while she was in hospital. That wouldn't have been able to happen before, because we wouldn't have known she'd been in hospital until after she'd been discharged. The fact that we've got timely integrated information allows us to start thinking about how do we work proactively with other services to prevent admission, prevent illness. And I quite like that as an example. So if I hand back to you, Rob. You're mute.
Thanks, Jonathan. Yeah, struggling with the technology here. Yes, okay. So I spoke earlier about the dependency on FHIR, fast healthcare interoperability resources. For those of you who work in healthcare, then FHIR is probably a very familiar concept. For those who don't, probably a little bit more foreign. FHIR is a maturing standard. I would say it's a mature standard. actually, for both representing a data model, a healthcare data model, as atomic resources, and also as a way of actually structuring application programming interfaces to allow access to data and to allow data to be shared between systems. So at the heart of the Yorkshire and Humber Care Record is a FHIR data model. I talked about atomic resources. What I really mean by that is concepts in healthcare, events and actors are represented as well encapsulated data structures. So within FHIR, there is a data structure that represents a patient, data structure that represents an encounter between a patient and a practitioner, data structures which represent observations, maybe blood test results, etc. And the data model is fully fledged and allows these to be interrelated with each other and to provide context of care. So when looking into the Yorkshire and Humber Care Record, what a data consumer sees is a longitudinal care record, which is assembled as FHIR resources. Now, one obvious application of that is to see a snapshot of the patient or a history of the care that a patient has received, to see a snapshot of the medications that a patient is currently being prescribed, a snapshot of the allergies that a patient suffers, the conditions that they're being treated from, etc. But a byproduct of collecting FHIR resources, data from our data providers, is that the Yorkshire and Humber Care Record also presents a picture of how patients are using the health and care system. Whenever there's contact with a healthcare organisation, FHIR encounters are created. And looking at that sequence of encounters that a patient has had with healthcare providers tells a story about how people are using the care providers in Yorkshire and Humber. You know, the graphic here describes a particular patient journey. It talks about Alice, an elderly patient who's recovering from a fall, presented in an emergency department in an acute unit, was admitted as an inpatient to a ward, was subsequently provided an outpatient clinic appointment, and at that outpatient clinic appointment there was determination that Alice would benefit from physiotherapy services provided in the community. Whilst under the care of community, that it was felt appropriate to refer Alice to social care and perform a needs assessment within social care, potentially to look at how she was living and help her over a period of time. Now, you know, each of those FHIR resources that are available from each of those care settings, each care setting has its own particular focus, its own particular perspective on part of that pathway. But looking at them more holistically, it's possible to join up the pathway and understand a clinical process that's actually occurred with an individual patient. There are gaps, you know, in that process, and there is information which really needs to be derived actually at the regional level. Encounters really need to be able to tie up, episodes of care need to be modelled that link together encounters at individual care settings to develop a holistic understanding. But once that's done, there is the YHCR almost offers a self-documenting process for how the healthcare system is being used. And I think this really is quite interesting for health opportunities in changing healthcare. So, Jason, I mean, over to you to talk a little bit about that. Jason, you're on mute now.
Sorry, can you just get back to the previous slide, Robert? Because just an additional point I want to make about that previous slide. In that, actually, you know, when people are working, they're working in their own systems within their own organizations. They're not having to think about this because the information has been translated from their systems. The actual view that people can have of an integrated record like that is built in real time by extracting the information from all the different systems, rather than having to change the way that people are working and using systems. So, you know, when I'm working in my practice, I'm still working in my clinical EHR. When people are in the hospital, they're still working in their system, but they can draw into that holistic view of other information that other providers have to create this longitudinal record. So they're not having to duplicate it in any way. It's there in real time to help with care. Robert, if we move on to the next slide. I think what this gives us, yes, direct care opportunities are great, but I think when we start thinking about either quality improvement methodology or thinking about transformation of services, I think in general, within health and care, definitely as clinicians, we are not very good at understanding the processes that people are following. So we talk about care pathways, but in general, care pathways are around a single complaint. It might be guiding us about referral. It might relate back to some evidence base for how you do things, but they tend to exist in silos of care. And by freeing up the information here, what we can do through the YHCR is say, actually, let's have a look at what's happening with a more helicopter view. So yes, let's build it on real live information about how people are accessing care now. But what does that look like if we look at different populations or the population overall about where people are going and how they're using it? And if we were to say, pick on a subpopulation, so something like those who are frail, and were to look at how they en masse or in a specific geography are interacting with services, what would that tell us? How do we think we are going to best meet the needs of those people, and how far are they varying from that? How much are we varying from that in the way that we manage those people? And I think what we've started to put in place now is the technology to allow us to really understand that. So if you have a look at some of the best organizations in the world in health and care around quality improvement methodology, people like places like Intermountain in Utah and such, integrated care systems like that, then actually what you see is that there is a move towards standardization of care around the widest possible pathway where possible. But actually what they say is, well, we can standardize the care 85–90% of the time, but we expect people to vary that care 15–20% of the time. And the reason that we think that is because everyone's different, and there's always a degree of personalization in the way that we deliver care, especially as it becomes more complex. However, what is important is that we need to be able to measure the impact. So we can assess when variation is good and when variation is not good, and we can therefore make sure that what we standardize is the right thing to standardize. And you can only really do that when you're being able to take the information from life care and then look at it in a more abstract way like this. The other thing is trying to think what we're trying to achieve. So I think we spoke before a little bit about how, rather than thinking about the outputs, what's the activity that's going on, to more about what are we trying to achieve and are we achieving it? So how do we start measuring outcomes, and where is the information to understand outcomes within the integrated information that we have? Because when we start looking at the data in this way, we can start creating personas, understand the use cases. We can say, this is what's happening to this population. This is how they're interacting. These are the problems. And we can start using a bit of clinical validation with groups of clinicians and with citizens themselves to say, well, actually, what should we be doing better? What are the services that are missing here? And when we do try a new service or a new intervention, how do we assess whether it's having an impact or not, so that in the future we can guide people to use those things more effectively. If we move on to the next slide. This is a slide that's used by NHS England, and effectively what it shows is an intersection of some of the things that we've been discussing here, but the information that we have allows us to start thinking about operating in this way. So when we look at a population, we know that there are some things that we just need to do for everybody. So it may be about weight management services, or it may be about smoking cessation services, or it might be screening or cardiovascular checks in the over 40, to try and be more preventative in the way that we provide care. Who those people are probably doesn't matter as much in terms of developing those services, but understanding what impact they're having is. Now, as people start developing other conditions, higher risk individuals, the approach needs to be more targeted. So if you're looking at someone with multiple long-term conditions or people living in deprived areas in poor housing, actually the interventions that you're starting to develop need to be more targeted in that way. It's a way that you can look at health inequalities. It's the way that you can also look at socioeconomic inequalities. You target what is needed to the place where it is required. And again, you need information to be able to target that. And then, of course, you get those with real complex needs where actually you can only probably do specialized integrated approaches. It becomes immense personalization at that point, because it's like we mentioned before, if someone's living in a deprived area, poor housing, smoking, lung disease, heart disease, and they're having recurrent admissions because of exacerbations of their lung condition, actually the intervention isn't necessarily just about treating an acute respiratory illness or managing that medically. It's about looking at the holistic needs of that individual in terms of their housing, in terms of loneliness, etc., etc. And this shows how important it really is to be able to build up that holistic picture of individuals and relate it to the risk and the potential interventions that you're going to use in order to achieve the outcomes that you're aiming to do. Back to you, Robert.
Yeah, thanks a lot, Jason. So many of the themes that Jason's spoken about relate to standardizing clinical processes, but also to being able to personalize those processes to individual needs. Now, to be able to standardize processes requires an understanding of what processes are operating and what should be operating. And so, you know, a focus of the Yorkshire and Humber Care Record really is it's moving from being quite a technical program to being a program that is trying to understand what's really happening on the ground. And I'd like to talk really about 4 different instances of where formal modelling of clinical processes is benefiting the YHCR. 3 of those are very real. They're tangible process. They're tangible initiatives that are working on the ground and are improving the way that care is delivering now. The 4th one really is an aspiration, and I want to sort of paint a picture of where we would actually like to take the Yorkshire and Humber Care Record and how we would like to deal with clinical process modelling actually in the future. So one of the key challenges to operating a shared care record is standardizing the representation of data coming from different care settings. So, you know, one of the very basic concepts in a shared care record is the idea of an encounter. But, you know, something we found actually on our journey is that, you know, even just defining an encounter in a way that's common across care settings, even just looking in acute hospitals and saying, you know, how do you consider an encounter within your hospital varies quite dramatically with one of their neighbours, let alone as we then move into community care and social care as well. So one of the initiatives which is running in the Yorkshire and Humber Care Record is a data maturity initiative that is trying to understand how different care settings are offering their data to the Yorkshire and Humber Care Record, to understand where those deviations actually lie, and to work out how we can actually mature individual data provision to a standard where comparisons can be made between care settings. This slide really talks about that journey that Alice had through a hospital where she presented in an emergency setting and then was admitted into an inpatient and referred to community services. And here we see 4 different hospitals in Yorkshire and Humber that are treating that problem or representing the problem in very different ways. The theoretical, you know, FHIR actually is a very flexible data standard, and you know, the advantage of that is it affords opportunities to look at the problem in different ways. A disadvantage is that if you have 4 people looking at a problem, there are probably 4 different answers to the solution. You know, the simplest representation of Alice's journey is to consider the period of time actually within the acute hospital as a single encounter. that the Alice presented in ED and was moved to a ward, but that can be represented as a change of the class of encounter within that single encounter resource. The movement between ward locations as well, locations of the hospital, can be represented within that single encounter. Nobody in Yorkshire and Humber is taking that simplistic view. I think everybody in Yorkshire and Humber is actually distinguishing between an emergency encounter and an inpatient encounter, but there are certainly degrees of differences of representation. So in Doncaster, for instance, there is a single inpatient encounter presented to the YHCR for 2 possible ward stays, which is fine, but it's not how that's happening in Harrogate. And in Harrogate, where a patient moves between wards, an encounter stops, a new encounter starts, and any clinical events occurring in that second ward are attached to a different encounter. The Yorkshire and Humber Care Record has a model of where we would actually like to take these organisations to, and that's sort of represented at the bottom, where we would like to recognise the fact that there is something called a hospitalisation, which spans the custody an acute unit has over a patient during a stay or their contact with the patient, but also recognises the distinction between emergency encounters, inpatient encounters, significant movements between locations, and also envelops those within an overall episode of care, which allows causality of encounters to be established. Second area where clinical process modelling is being used significantly is looking as to how to apply the Yorkshire and Humber Care Record to particular care pathways and how to tailor its functionality to the needs of individual clinicians. So what I'm showing here is a model that was developed for oncology as to how the cancer treatment would benefit to access to the care portal and how the care portal would actually support that care pathway. And in doing that formal analysis, it's driven a number of design decisions within that care portal and has allowed functionality to be developed, which allows for the referring of patients between district hospitals and tertiary centres much more efficiently. And that wouldn't have happened without that sort of formal analysis of how the cancer pathway really was operating. The Yorkshire Ambulance Service is a very active participant to the Yorkshire Humber Care Record. The Yorkshire Ambulance Service obviously has contact with a number of care organisations across the entire geography. One of the initiatives that they're using the Yorkshire Humber Care Record for is to automate transfer of care from an ambulance into an ED department, to issue electronic notification that a patient is travelling to an ED department, to be able to expose vital signs from the ambulance as the journey is progressing, and then to deliver a patient record into the ED department as the journey is concluded. What Yorkshire Ambulance Services have found actually in trying to implement this electronic transfer of care is significant deviations in practices in different ED departments. At the moment, these deviations are handled by paramedics with knowledge of the particular circumstances of every ED department and the practices of the departments. But as we move to fully electronic transfer of care, that we actually need to iron out a number of those discrepancies and need to understand how they actually how they're going to be accommodated in the new electronic model. So this graphic really describes the key differences between a hospital in Rotherham and Leeds teaching hospitals, and how the systems operating in each ED departments can be aligned to actually interact with the electronic transactions emitting from an ambulance. Finally, I said I was going to talk about something which was aspirational, and this really is aligning our knowledge of how care pathways really are operating with the Yorkshire and Humber Care Record with a formal model of how we believe they should operate. We have the information at the moment, which tells us how patients are using the health and care system. We can draw a picture with some derivation of what a condition or treatment for an episode of care actually looks like. We can describe how a patient has moved through the various institutions in the Yorkshire and Humber Care Record. What we don't have at the moment really is the template, the baseline, which actually describes that for a particular pathway, how that should be operating. Now, were that to be in place, that it affords an awful lot of opportunities for analysing differences in practice, to understanding where personalisation of care really is impacting outcomes, and where personalisation of care is possibly leading to inefficiencies in the use of the health and care system. So, one of the, I will predict that within the next sort of 12 months or so, one of the subjects which will be on the Yorkshire and Humber Care Record desk is to say, how do we actually relate the data that we're pulling from the Yorkshire and Humber Care Record as to how pathways are operating with some form of model of how they are. My anticipation is that this model will be developed on a pathway by pathway basis and according to as need, but I think we can foresee it happening. So, just really wanted to finish with what are the barriers that we face to formalising process-led care, to using formal definitions of clinical processes to actually improve care. I think one of the fundamental problems that exists is lack of uniformity in the way that data is presented to a shared care record. That there is a large degree of discrepancy in maturity between care settings. Some care settings are offering an awful lot of structured data, others are offering mainly textual information about what's happening within their boundaries. Being able to track a care pathway regionally is a problem for formal processing modelling. There is no information or very little information in the healthcare system to establish causality of events in different care settings. Sure, where there is a formal referral request can be identified, maybe it can link one encounter to another, but mainly that it has to be implied as to why the care settings were providing the care that they were providing. Certainly, there's a lot of complexity in the health and care system. Complexity really shouldn't stop progress, but there is, it's hard work dealing with that complexity, and it's a very costly process, modelling clinical processes, and we really do need to align those with value. But I think there's a lot of hope there that things are changing. I mean, what we've seen with the Yorkshire and Humber Care Record is that its very presence enforces data standardisation and promotes maturing of data. The fact that we can measure the quality of data within the Yorkshire and Humber Care Record, the byproduct of that is there are initiatives to improve the quality of data, and we've seen major steps in the last 3 years in terms of standardising the way that data is actually offered. That the fact that we have regional terminology services operating in the Yorkshire and Humber Care Record makes it a lot easier to apply coding to data. And I think we're learning how to do that, which as a byproduct means that data becomes comparable between care settings. The very presence of the shared care record, it's catalysing and thinking about how care pathways are joined up. There's a lot of work taking place in Leicestershire at the moment, which are also a user of this technology, on discharge coordination between social care and acute care. The only reason that work is taking place at the moment is the ability to actually share information at the point it is shared needs to be, and to allow the dialogue to happen between social care and acute care. As integrated care systems are formalised, as they take on legal status, as they have teeth, I think we're going to see a change in emphasis in how care is delivered actually across a region. And inevitably, this means consideration of regional clinical process management, which I think will act as a stimulus for much more formal modelling of the processes operating within the ICSs. That's all I had to say. Jason, is there anything you want to conclude with?
I think there's a couple of things just on the barriers as well. I think that there is a key point, is that actually digital maturity across health and care isn't universal. You know, you can't draw the information when actually it's on a piece of paper in someone's cupboard somewhere. And so, you know, this becomes more useful as more information becomes accessible. And actually, in healthcare in general, whether it's in hospitals or not, the use of electronic health records is increasing. But actually, you know, increasingly we're going to need more information from social care or wider areas within local authorities, and there's variability both in terms of digital maturity there, and also again quality of data as well, to be able to use it for this purpose. And then there are areas that are probably really important that we haven't even started to discuss. So care homes, third sector organisations who are increasingly important in supporting health and care services, actually digitising their information and professionalising it is something that we will need to look to going forward if we're going to make the most of this type of technology.